Good afternoon, everyone, and welcome to today's webinar presentation, How One Health System Uses Data for Physician Engagement. Before we begin, I'd like to cover a couple of housekeeping items. This webinar is being recorded and will be available for replay later this week. All attendees will be on mute for the entirety of the webinar. If you have a question, please submit them via the Q&A text box to the right of the screen at any time during the presentation, and we will address them during the question and answer portion. As a follow-up to today's presentation, you will also receive an email that includes a PDF of today's presentation and recording. Thank you so much for joining us, and with that, we will start today's presentation. Your moderators for this session are myself, Kristen Weir. I am the Senior Vice President of Product at MediAnalytics. And Scott, do you want to introduce yourself?
Yeah, thanks, Kristen. Scott Hampel, I'm President of MediAnalytics. So MediAnalytics is a healthcare data analytics company. We've been around 25 years. We're servicing around 2,400 hospitals, 32 health plans, as well as the public sector. So that's our background, and we're excited to have our guests today. I'll turn it back to you, Kristen, to introduce them.
Great, thank you. Today we have Adrienne Younger. She is the Assistant Vice President of Clinical Documentation Integrity at Ardent Health Services, where she oversees Ardent's clinical documentation improvement initiatives and manages the coder and physician education for all markets. Adrienne, leveraging her past experience as an RN, also manages a team of CDI nurses who perform pre-bill reviews. And we have the pleasure of working with Adrienne today. Trevor is actually not going to be part of this session, so we will be interacting with Adrienne as we move forward.
Great. So just a little bit of background about Ardent Health Services. So I think probably many of you folks are aware of Ardent Health Services. And this is a large and, I think widely recognized health system. Headquartered in Nashville, Tennessee, 4 divisions, including 31 hospitals, over 4,000 beds, 25,000 employees, and over 1,000 employed providers. And I also did some of my own research, and very frequently reported as one of the best places to work in healthcare. So excited to have Adrienne join us from Ardent. And with that, I think we can move to the next slide. So Adrienne, could you please share a bit about your role at Ardent and acquaint our guests as to the function that you perform there?
Sure. Can you hear me okay?
Yes, we can.
Okay, thanks for having me on. And it's unfortunate that we all couldn't meet together in Orlando, but still very excited to share our story at Ardent and how we've leveraged MediAnalytics to help us. So as mentioned, I'm over all of our CDI programs. And also I have a large remote team that does pre-bill and secondary reviews that are also CDIs that hold a little bit different background. And then I do work very closely with our Assistant Vice President of Coding. We kind of fall under the HIM umbrella. And then also I work very closely with our quality department as well.
Great, thank you, Adrienne. How is your department structured, and if you can tell me a little bit about what staff you have?
Sure. So as I mentioned, CDI is up under our finance head umbrella, and then I report directly to Trevor, who was not able to join, who's our VP of HIM. Our CDI department actually is structured, it's kind of a hybrid model. So we have concurrent CDI teams in 13 of our hospitals. Out of our 31 facilities, we've got a concurrent team on the ground in the hospital in 13 of our facilities. And then we also have what we call our health information integrity team that we built about 4 years ago, and they also are part of my program, and they work remotely, and they actually review charts across all 31 of our facilities in a pre-bill review format. And then again, that kind of covers that second question of what staff do we have. We've got a hybrid of different folks who make up our concurrent CDIs. Majority of them, I would say 90% of them are registered nurses, and then we've got a few who hold a little bit different background, whether it's RHIA or RHIT, or we've even got a couple of respiratory therapists as some of our CDIs. And then our remote team are all registered nurses. And that our remote team makes up about 45 CDIs who do our pre-bill review, and then combined our concurrent CDI teams make up about 50 folks.
Great, thank you, Adrienne. Next, what did Ardent's clinical documentation improvement program look like when you started?
So back in 2015, which is when I transitioned from one of our, being the CDI supervisor in one of our facilities over to our corporate office, that was around 2015. And at that time, we had 3 main markets. So we weren't near as big as we are today. But our clinical documentation improvement programs at that time in those 3 markets really functioned at the facility level. We didn't have a corporate support system for CDI. So each of our CDI programs solely reported to the HIM directors in those markets, and then kind of each had a little bit different platform, and we didn't have a pre-bill. Back then, we didn't have a pre-bill review program like we do today. So it was really just our 3 concurrent CDI programs, and they really kind of functioned in a silo platform.
Okay, great. Well, thank you for that, Adrienne. And when we talk about clinical documentation improvements, can you tell us a little bit about what were your challenges for CDI at the time?
Sure. So when I came over to corporate and we decided to bring CDI together at the corporate level, we were what we call facing kind of the perfect storm. So that was when we were on the brink of ICD-10, and we knew that was going to be a big change for all. We also had a change in our leadership at the corporate level. So we got a new VP of HIM, our coding leadership changed, and then at that time I was brought on, and we decided that we wanted to bring all of our CDI programs up under one system so that we would have standardized goals and metrics. At that time, a big challenge for us back in 2015 was each CDI program utilized a different software. So we weren't all on the same EMR. And then they also, one facility used one CDI tool, another facility used just the encoder. So we were left with trying to figure out how to merge all of our programs into being able to report the same way so that we could have a standardized approach when we were going to report out our goals and our successes and our metrics, because we didn't have the capability to do that back in 2015.
Great, thanks, Adrienne. How did you assess physician documentation performance, and did you have any way to determine where improvements were needed?
Right, so we really didn't, and I kind of call it the needle in a haystack approach. We would often get asked by a CFO, our CMI dropped, what are the physicians doing wrong? Or, why is our CMI falling? What do we need to do about our physicians and how they document? And we didn't have a really good way to determine where it was coming from. Basically, our only option was to pull a list of discharged patients that had been coded for that prior month where the CMI variance occurred. And we really just had no choice but to just pick and choose and hope we came across something that showed opportunity where we could take that back to the physician. The problem was many times if you just picked the right charts, our answer back to the CFO was, we're not sure why the CMI dropped, or we're not sure why the CMI increased. Every chart we looked at was exactly what it was supposed to be. So we didn't really have a good way to assess physician documentation performance in regards to what area do we need to focus on. It was more of a, let's just hope we pick the right charts that are going to show us some opportunity. And again, it was more of a, from an education standpoint, it was more just global education, because unless we just happened to stumble upon a record that we could use to our benefit to really support why we saw any variance in metric, we just kind of had to go in blind and try to attempt to figure it out.
With that said, Adrienne, what CDI goals did Ardent establish? What was the timeline, and who was involved in executing on those goals?
Right. So back then, and I keep using 2015 because that's when we kind of really changed our concept, is we knew what goals we wanted to report on a monthly timeline, which, are pretty much those that you see across the industry. We wanted to be able to set a goal for MCC capture rate as far as just being able to trend it. CMI, severity of illness, risk of mortality. Obviously, our CDI metrics also incorporated how many charts are we able to cover, and we would set a goal for that. What we learned is we really needed a way to figure out how to staff our CDIs across the units and service lines so that we could meet the goal of an 85% coverage of Medicare charts. And, before we really had the ability to see where our opportunity was, we spread them out the best we could and hoped that we met that coverage rate. But we needed, we obviously wanted a way to be able to put our CDIs in the areas that we knew not only would find opportunity, but also the biggest population areas that would help us reach our goals. In terms of who kind of figured out, who was involved in making this happen. So in the beginning, it was really, just myself and Trevor at the HIM corporate level. And then across, over time, we've obviously grown our teams to incorporate CDI leads and supervisors. But really at the time, it was just Trevor and I really figuring out what we wanted that CDI program to look like.
Okay, thanks, Adrienne. So what changes in terms of processes and tools did you put in place to support the achievement of your CDI goals?
Right. So again, I think the number one change we knew we needed to make was figuring out a way to report the same across all of our markets. So however we trended CMI in our Albuquerque, New Mexico market, we wanted to make sure we did the same in our Tulsa, Oklahoma market. So that was one change we knew we wanted to make immediately, was standardization. And then again, we knew we needed a way to be able to drill down to find exactly where our opportunities were. And we needed a tool to help us develop those processes. I mentioned CDI staffing. We needed something to help us figure out where each facility's opportunity was. We didn't want to say, we're going to focus all of our efforts in cardiology across the organization, where maybe one facility didn't really need everybody focusing on cardiology. And we didn't, at the time, we didn't have a good tool in place until we put in meta-analytics to help us know exactly how to staff and what processes to put in place for each of our 30 hospitals. And they're not the same when you think about opportunity. How we report our metrics is the same across the organization, but how we staff our CDI teams and what DRGs we focus on are different across the organization. And the meta-analytic tool helped us get that process and plan in place.
Wonderful. Well, how do you determine who your top performing physicians are and where there are opportunities to improve clinical documentation? And if you could tell me a little bit about the metrics, what metrics you measure.
Right. So now that we have meta-analytics at our fingertips and we use that every day, we really look at, it was kind of a light bulb moment when we started using Medi, figuring out how to completely change our process to be service line driven. So instead of comparing all physicians and looking at all of their CMIs and trying to pick which physician is doing the best, we really felt like it was more beneficial to look at each individual service line. And so, we can pull cardiology as a service line and look at every physician that falls within that service line and measure their, the metrics that we feel are the most beneficial in determining the success of your program are really MCC capture rate and severity of illness and risk of mortality if we're thinking about metrics that are specific to physicians. You know, CMI can have several variables that go into whether or not it's increased or decreased. And, you know, one physician's patient volume may be much smaller than another. So if you take out the volume piece and you're just really looking at that MCC capture, that's more of a gauge on, regardless of how many patients they take care of, their MCC capture rate should be, you know, kind of equal across the board if they're taking care of the same type of service line patient. And then severity of illness, risk of mortality. So if we were going to do a quick glance and I wanted, you know, to quickly see if any physician for any given month in cardiology stuck out, I would be looking at that MCC capture rate and their SOI and ROM score.
How do you share documentation performance then with your physicians, Adrienne?
Right. Before we had meta-analytics to help us, we really had to just kind of share global where industry says most physicians have opportunity to improve. Now we can actually, we share in various different avenues. We share through newsletters and tip cards, and we're big on webinars, so we do hold webinars with our different service line physicians. And where we, you know, have found the most benefit with MEDI in regards to physician education is being able to drill down to a case level detail and show them the opportunity from their actual live case. You know, many physicians, if you show just a global education tip, or you say, you know, industry says physicians, you know, don't capture acute pulmonary edema as often as they should. Most physicians will say, well, I know I do. So it makes a bigger impact if you can show them their actual cases and share with them exactly where that opportunity was and walk through it with them instead of just kind of doing a global case scenario.
Yeah, that makes a lot of sense, Adrienne. What are Ardent's future plans for its CDI program?
Right. So obviously, you know, we're constantly in brainstorming mode. You know, our motto is get comfortable being uncomfortable. We're always looking at ways to grow the program. I would say just over this last year, we've really tapped into meta-analytics to help us grow the quality piece of our CDI program. How can CDI become more involved in things such as HCCs and patient safety indicators and hospital-acquired conditions? And how do we need to be looking at these from a CDI perspective? And we were able to develop several new processes over the last, I would say, 6 months even. Sepsis, for example, we were able to use meta-analytics to see where we're at with sepsis, where are we at with sepsis as a short stay, and then we were able to put some things in place for 2020 for our CDI programs to really look at certain areas. And we were able to do that because we could pull several different statistics and reports out of meta-analytics to help us set our 2020 and beyond goals.
So the analytics that you're using, Adrienne, how has that contributed to the success of your CDI program?
Yeah, so this one I could talk all day on. I would say there's several different things we've been able to do to strengthen our CDI program through the use of meta-analytics. And a couple that stick out to me that we discovered along the way that wasn't necessarily something we started out doing was really figuring out how we could use that tool to staff our programs. There are certain areas, certain service lines where CDI can have a bigger impact. And by using meta-analytics for each individual facility, we could figure out exactly where we needed to put our folks. And what that did was allow them to review those records that yield the most opportunity, whether it be to have a conversation with a physician or to place a query on the chart or to discover that we needed to create some education for a particular diagnosis. but it put them in the spots that we knew they would be most successful. The other thing that it has really helped us do and helped us really get CDI out and get the other multidisciplinary teams to really understand how CDI can help. And this was another kind of one of those light bulb moments that we really didn't track or look at, I would say, up until about a year and a half, 2 years ago, was length of stay, and really starting to look at how can CDI play a role in managing length of stay. Historically, that's always been something that typically was driven by case management, but we started thinking, if we're the ones that are reviewing the documentation and we're the ones that are assigning those DRGs, then how can we help with length of stay? And it kind of started because I had a facility come to me and say, our length of stay is really, taking a turn. Can you help us figure out why? And so we tapped into meta-analytics, and we really started looking at, where is it coming from? What service line is really driving the length of stay to be higher than the geometric length of stay? And what that did was allowed us to come up with a plan. We even got down to the level of what DRGs in any given service area yield the most volume that probably contribute to the higher length of stay. Once we were able to do that, we could pull some of those cases from that particular service line with that DRG. We could have our CDIs look at them. It was not only a learning experience for us, but it was also a way for us to know, what do we need to take back to our CFOs, and what do we need to take back to our case managers? And it was getting down to that detail where we could almost say, DRG sepsis and DRG heart failure are the two DRGs that are causing our variance in length of stay. Then that allowed us to put a process into place that, CDI could alert case management and work very closely with them. If they reviewed a record with this DRG, they put a query on the chart, they found an opportunity to improve documentation, and that was just something that we just historically never really looked into how we could play a big role. But I get excited when I talk about that, because it's really been fun to watch how our CDIs have really learned how important it is to get that right DRG on there, and how important it is to get that correct principal diagnosis. And we would have never had the ability to be able to get down to that granular of a level if we didn't have meta-analytics to help us know where to focus and know where to start. Another thing that I think Medi has done to help us just achieve where we're at with our CDI programs is being able to look at DRG opportunities. So, we look at MCC capture rate every month, and if we see there's a particular service line that has a lower MCC capture rate than it has in previous months, that's how we base our CDI audits. Are we missing opportunity? Do we need to shift our staff around because one is a little bit better at cardiology than another? So it just allows us to also provide real-time feedback back to our staff so they know where their weaknesses and strengths are and where they need to work. Another thing that it's allowed us to do, and this is really just the overall success of Ardent, is meta-analytics has helped us anticipate any future risk areas. So if one of our facilities is audited or gets a CMS audit, or they go through, they get a denial, and Medi allows us to take that information that we've already received from one facility, and we can look at all of our facilities to see if we're going to possibly have the same issue. One of them was severe protein calorie malnutrition. We had one of our facilities go through an audit. We wanted to see what that volume looked like in the rest of our facilities, and meta-analytics allowed us to be able to pull those records. We could look at them. We put some processes into place to allow us to be able to have these routed in our EMR, and so we could look at them and almost kind of prevent any future risk areas, because we can anticipate and pull the data before someone else does and alerts us to that.
Great. Thank you so much, Adrienne. That was great information. We will now accept any questions from our participants. And as a reminder, feel free to submit your question in the chat. There's a chat bubble at the bottom of the screen. So first question is, what do you feel is the biggest challenge in getting physicians to change their behavior?
Stubbornness is the biggest challenge, I would say. And that obviously is a challenge. You know, we just kind of had to overcome a hurdle with, you know, getting them to change their behavior and how they classify an acute MI. I think it's repetition. And again, I would say stubbornness obviously is the biggest challenge, but what we feel works best is if we can show them, if we can get 5 minutes with a physician and we can say, let's walk through this case together and let me show you the opportunity and let me show you the coding guideline and let me walk you through, you know, why we're in this predicament or why we feel like this is a risk area. And once we can kind of put it all in front of them, show them their current documentation, show them that rule or that guideline. Right now we have a big focus on denials. Show them exactly what that payer is looking at. Then I think we can start to change their behavior and documentation.
Great. And this one kind of piggybacks on that one, Adrienne. How do you engage your physicians to drive performance improvements?
That's a good question too, and that's been one that we've constantly had to think outside the box. You know, we've tried several different things. You know, obviously it's hard when you have an organization with several facilities and you know, in different parts of the region and different cultures. And I think again, it's getting them to buy into what's in it for them. We've all heard that. You know, it's not about the money. You know, what does it look like on paper or on a leapfrog report or on a mortality report? How does it reflect them as a physician? And so I think, you know, the more we can show them how that looks, the more we can get their buy-in. We also, you know, persistence is key. You know, if at first we fail, we just try again. And I think by almost bugging them, they've finally learned that we can help and we're going to insert our foot at every service line meeting we can. You know, we just go at them at several different avenues.
Great. Would you share a little bit about your experience with regards to implementation of CDI programs at inpatient versus the ambulatory level? And second part to that is, how have you integrated inpatient CDI and ambulatory CDI programs? Right.
So, you know, we don't have, obviously we don't have a full functioning outpatient or ambulatory CDI program. We do interweave. So, you know, back 2 or 3 years ago when everybody first started hearing about HCC diagnoses and how that was going to play a huge role in outpatient and you know, bleed over to inpatient. We, you know, the outpatient CDI, I think is still kind of that dark. You know, nobody really knows what the impact is going to be from that. So what I would say is, while we don't have CDIs who solely function in the ER or in our clinics, we do have CDIs who, you know, if somebody is admitted from a clinic into the inpatient setting, we have a communication with our folks that do our clinic coding and billing and HCC capture, and we have a way for them to alert our inpatient CDIs that Mr. Smith is in the hospital. This is a diagnosis that we really need the doctor to clarify if it's still being treated. So our inpatient CDIs do work closely with our clinics, but we don't have a full-blown outpatient CDI program.
Okay, great. Do you have key metrics that you evaluate your physicians on?
We do. So we evaluate them on MCC capture and severity of illness, risk of mortality. And then we also measure, these are the things we measure monthly, is their length of stay, their individual length of stay. We also incorporate CMI because that's kind of a given. but we've done we also, really have to take into consideration there are other variables that can impact a CMI. So really that physician's length of stay, their MCC capture, and their SOI-ROM. And the reason we do those three is if I have a physician who consistently keeps their patients 2 to 3 days longer than their peer within that same service line, but their MCC capture rate is lower, that's a good indication to me that we probably have some room for some documentation opportunity. Why is he keeping them longer, but we're not getting those secondary diagnoses on the record that would support that?
Great. Thank you for sharing that. This is an interesting one. What attributes should I look for in analytics technology?
That is a good one. So again, I think if I were to just give one answer, it would be the ability to really get down to that absolute level of detail that can give you the answer you want. If you don't have an analytics tool, again, it's more of a guessing game. It's more of a, well, I think I could tell you why the CMI went down, but I'm not sure. So to me, the biggest attribute for any analytic software would be that it allows you to continue to drill down until you've got enough data to be able to give a confident reason of why any metric that you report has had a variance.
Wonderful.
Oh.
I think you'll like this one as well, Adrienne. Did you have support from senior leadership from the beginning on from the beginning on utilizing this type of tool? We did, because I think senior leadership recognized that they wanted to be able to have more data. Because again, when you see any variance in a metric that any hospital reports on, you want to know why. And so they knew we needed something to be able to give them that feedback so that they could report a CFO can report in their monthly operating meeting to our senior vice president at Ardent. They can report our CMI took a dive and here's why. It turns out we didn't have as many, ventilators this month, or it turns out that we looks like we didn't have as many, cases fall into our sepsis with an MCC as we did last month. And then they can give an action plan. And, with that, we're going to be looking at these cases so they can already kind of, answer the questions that will probably be asked of them at the corporate level. Perfect. Thank you. And then we had a user ask, we have people with all different backgrounds that attend our HIMSS sessions. They asked, what does CMI stand for? And that's Case Mix Index. If you want to elaborate on that, Adrienne, feel free to. Yeah, so basically Case Mix Index is kind of a reflection of, how sick is your patient. CMS gives a case mix index for any particular DRG, and based on the volume of patients you have in any given month, what's the DRG that was coded on those patients, and then the formula kind of spits out a case mix index, which is really the severity of how sick your patients are. So if you have a case mix index, in your cardiovascular surgery service line that's really low, those are DRGs that have a high assigned relative weight. So if the CMI is low, did we get them in the right DRG? Do we have room to improve our documentation? Was it a volume issue? It really just kind of is an indication of how sick your patients are. Great, thank you. Okay, another one that's come through. Do you provide any incentives to your physicians for improving performance? Not at the corporate level. So that's kind of driven by each individual facility. Some of our facilities do have incentives built into their employed physicians' contracts, but it's really more off of a facility-specific contract with, some of our hospitals, majority are employed physicians. Some of them, majority are not employed. So it really just kind of depends on that individual facility, but we don't offer any incentives at the corporate level, other than a good pat on the back. which is always helpful as well. Um, great. And you touched on this a little bit earlier, Adrienne, but what have been the outcome of Ardent's physician education and engagement initiatives? And have you seen a culture change over the years?
We have. So I think, in the beginning, obviously, I think, 10 years ago, 15 years ago, everybody knew kind of what a CDI program was, but I don't think we got the support from the physicians that we do now. And I think, once we started really showing them how it could impact the type of physician they appear to be, what type of patients that they take care of, then they wanted us to come and give them documentation opportunities. They're not taught coding guidelines. They are not aware of when CMS rolls out, a different criteria, or when sepsis 2 versus sepsis 3 hit the market. They want us to show them, those opportunities, and they want us to show them why what they say doesn't always equate to the same thing in the coding world, because they don't get that in any different avenue unless they're just really abreast in what's happening in the industry. So I think just through constant education and, them getting feedback from their CMOs on, our mortality scores are low, make sure you're doing the right thing, they come to us now and say, can you come talk at our service line meeting? Or, you put out this tip card and I saw it in my email, but I don't really understand what it is that you're wanting me to do. We have definitely seen an impact in our physician buy-in to CDI. And it was really more just us saying, we're not going to take no for an answer. We're going to get in, even if it's 5 minutes on any agenda that we can get in on, we're going to take the opportunity.
Great. Thank you. Another question that has come through is, how have you been able to grow and scale your CDI program across the Ardent enterprise?
Yeah, so, we have rapidly grown over the last 3 years. Like I said, when I came to the corporate level in 2015, it was basically 3 markets, Albuquerque, Amarillo, Texas, and Tulsa, Oklahoma. And now we've grown to 30. And so what we've been able to do is, not all of our facilities have CDI programs, but I think if you think about how we grown the ones that we have just within their own facility, it's really, what do we need to be taking on that we didn't do 5 years ago? Traditionally, when CDI started, it was all about get a DRG, find that MCC, and you're done. We didn't look at quality. We didn't help case management. We didn't really have a huge footprint with physician education. And I think if you think about how we've grown our teams, we've pushed our folks to really kind of see outside the box. And our CDIs now, really have a better understanding of what is a PSI, or a patient safety indicator, what is a hospital-acquired condition, and how can documentation cause us to take a hit or a ding when maybe it really wasn't a hospital-acquired condition, but the documentation was in such a way that it was coded at that. So our CDIs have grown to really start looking at, what can I do today? What can I possibly have an impact, today, whether it's through a query or through physician education, that actually will impact the outcome in 6 months. So if I query today to increase the risk of mortality score from a 2 to a 4, that's going to have an impact at the end of the quarter when CMS publishes our mortality reports. So what I do today may not have an impact in the actual DRG, but it has an impact in the outcome down the line. And so that's how our CDI programs have really grown, is they just have a better understanding of what their true role is.
Wonderful. And I'll pose a question to our attendees. Does anybody else have another question? We've had some great questions come through. Again, you would enter those in the chat. I have a great expert on the line who's shared a wonderful experience with us. Just wait a second here, see if anything else comes through. All right. Well, thank you so much to Adrienne Younger for being a part of our session today and sharing the experience that Ardent has had throughout the years as they've grown their CDI program. We really appreciate the insights that you've shared, Adrienne. I think it was really valuable for our audience. And I wish everybody a wonderful virtual HIMSS experience. I'm so sorry that we didn't get to see you guys in person, but we definitely hope to see you in person soon. If not at HIMSS next year, then sooner. And Adrienne, once again, thank you so much for being part of our session today.
Oh, absolutely. Thank you for having me.
All right. As a reminder, this will be circulated. We will send the recording in addition to the slides. You all are free to sign off now and have a great day.